This video summarizes clinical guidelines from the Royal College of Ophthalmologists 2018 covering recommendations on screening hydroxychloroquine and chloroquine retinopathy. We aim to cover the screening criteria, the screening protocol, including how to perform a baseline examination and how to perform subsequent screening tests, how to interpret screening results, and how to manage patients with possible or definite retinopathy. Chloroquine is more toxic to the retina, and as a result, screening should commence at 1 year. Hydroxychloroquine retinopathy screening can commence at 5 years, provided there are no risk factors for toxicity. If there are risk factors, these patients are more likely to develop toxicity and therefore should be screened at 1 year. Risk factors include using tamoxifen, which is also known to be toxic to the retina, having impaired renal function, and taking a dose of hydroxychloroquine greater than 5 mg per kilogram per day. Hydroxychloroquine only comes in 200 mg tablets. This table summarizes the minimum weight required in order to dose medication appropriately. The minimum weight for a patient taking 1 tablet a day is 40 kilograms, and the minimum weight for a patient taking 2 tablets a day is 80 kilograms. If they were to weigh less than this, then they would be taking more than 5 mg per kilo per day. The baseline examination should be completed ideally within 6 months and definitely no later than 12 months of starting the medication. The standard investigations to be performed are a fundus photograph and spectral domain OCT. If either of these investigations demonstrate any macular pathology, then please perform a 10-2 visual field. Screening for hydroxychloroquine retinal toxicity should be carried out yearly. 3 standard investigations for screening include a 10-2 visual field, OCT, and wide field fundus autofluorescence. A 30-2 visual field can be performed if there's an abnormal wide field fundus autofluorescence, but a normal 10-2 visual field. Multifocal ERG can be performed if there are persistent visual field defects consistent with hydroxychloroquine retinopathy with a normal OCT and normal fundus autofluorescence. Results can be classified as no toxicity, possible toxicity, or definite toxicity. When there is no toxicity, all investigations are normal. Possible toxicity shows one test result showing typical changes of hydroxychloroquine retinopathy, but abnormalities are not found in the other tests. Definite toxicity can be defined as one subjective test and one or more objective tests showing abnormalities typical of hydroxychloroquine retinopathy. Patients with possible hydroxychloroquine retinopathy should continue their drug treatment. Patients with one abnormal test on retinal imaging but normal visual fields should return for annual review as per the screening schedule. Patients with persistent visual field abnormalities in the context of normal structural imaging may be referred for multifocal electroretinography. Treatment should continue until the outcome of electrophysiology is known. It would be inappropriate for ophthalmologists to stop hydroxychloroquine treatment for patients with definite toxicity. A recommendation to stop hydroxychloroquine should be made to the prescribing physician to facilitate discussion between specialist and patient about the risk of stopping hydroxychloroquine and the options for alternative drug therapy. Some description by the ophthalmologist of disease severity may be helpful to facilitate this discussion between patient and prescribing physician. Patients should also be referred for appropriate support at the point of detection of hydroxychloroquine retinopathy. This may well involve low vision or eye clinic liaison officer services, certification of vision impairment, and referral to charities. Patients who are drivers should be advised not to drive until an estimate visual field test confirms it is legal to do so. The patient should also inform the DVLA. Thank you for watching this video.